Assalamu alaikum. Salatu assalamu alaikum, ya Rasul. This is the continuation of series of lecture on localized prostate cancer. Today's topic is the treatment and management of localized prostate cancer. I am Dr. Mohammad Numan. First of all, as you have all undergone the risk stratification and of EAU or NCCN guidelines, because we are following both in our clinics, this low risk, intermediate risk, and high risk dependent upon the PSA and the trust guided biopsy or transperineal biopsy of the pattern of the histology and the clinical staging on CT scan or MRI. Localized prostate cancers, they include the low risk, intermediate, or high risk up to the T2C, not beyond the capsule of the prostate. And this is the NCCN. In AU, NCCN, in AU, they have low risk, intermediate, and high risk. In NCCN, they have very low risk, intermediate, and high risk. This is the important slide. International Society of Urological Pathology. Gleason score 2 to 6 is a grade 1, and 7, 3 plus 4 is grade 2, and 4 plus 3 is grade 3. And if the score is 8, 4 plus 4, 3 plus 5, or 5 plus 3 is grade 4, or if the score is 9 or 10, it is a grade 5.
Excuse me, Noman. Can any resident tell the difference between 4 plus 3 and 3 plus 4? Go back to the previous slide, Noman. Here we can see the on two slides it is written 7, 3 plus 4 and 4 plus 3. Anyone who has done the on-core rotation? Yes, Kamal? Yes, right.
There is two terms for the very low risk group: active surveillance and watchful waiting. The active surveillance, the definition, the intent is a curative, and follow-up is according to the predefined schedule in the guidelines. And the assessment and markers are used for are DRE, 12 monthly, PSA 3 monthly initially, then 6 monthly, multiparametric MRI, and biopsy to reassess if the disease is progressing or not. Life expectancy, if more than 10 years, you can do the active surveillance. And aim is to minimize the treatment-related toxicity without compromising the survival. And these are very low-risk patients. In watchful waiting, the intent is only palliative and the patient-specific. There's no predefined, but the redevelopment of the symptom progression, and life expectancy is less than 10 years. So to minimize the treatment-related toxicity according to the patient's other comorbidities, and it can apply to the patients of all stages. For the
why are we using this terminology? Why these two terminologies are being discussed? Why active surveillance and why watchful waiting?
because
we had a discussion of a patient who was seen in the oncology clinic, and I had a discussion with one doctor. He said, "Why active surveillance? Give that patient upfront treatment. You have to treat that patient in active surveillance. So why are you doing active surveillance?"
There are different studies which have compared the two things, active surveillance and watchful waiting. Like Protect trial, they have enrolled about 700, 1600 patients, and they compared the both things.
No, I'm not talking comparison. I'm talking about a separate entity. Why active surveillance and why watchful waiting? I don't think so. They have got any comparison. Both are being offered to different group of patients. But why active surveillance?
If you can define them separately, then the whole thing will be.
In active surveillance, if the primary grade of tumor is very low, and the patient have very minimal comorbidities, and the percentage of tissue which we have retrieved from the biopsy, they are showing minimal component of neoplasia, we can offer active surveillance after discussing with patient and counseling him that if the life expectancy is more than 10 years, you can have your tumor with continuous surveillance. We will monitor the tumor. If it is progressing, and then there are further protocols in the guidelines to do the when to do the active surgery or when to do the further treatment for these patients.
And the concept behind this is that a patient has got a creatinine of 4, 3, 2. You prolong that creatinine to an extent that he becomes a completely end stage patient, and then you perform a transplant. उसका उसी दिन ही transplant कर दें, शायद उसको 5 साल बाद transplant की जरूरत पड़ेगी. So the same concept is for active surveillance. Maybe that patient does not need treatment at that moment, but maybe he will be needing treatment in future. So if you treat it early, then maybe वो जो उसको चीज secondary चाहिए हो आगे 10 साल बाद, वो 2 साल बाद उसको जरूरत पड़ जाएगी उसकी. So
Therefore, if the prostate is concerned, we all know that CA prostate is a very slow growing tumor, and it also occurs in the old ages. So this is why we also always measure the patient's comorbidity status as well as the life expectancy. If it is more than 10 years, and patient says even with the high risk disease, the risk of tumor morbidity is very low. So with the low risk disease, it becomes very minimal. So the main idea of active surveillance is to keep patient under your surveillance without promoting him and subjecting him for the complications associated with the curative treatment option that are radiotherapy and radical prostatectomy. And we all know that radical prostatectomy is a very cumbersome procedure. In past, even with the robotic, there are certain complications.
even
So
radiation and other
Yes.
things as well.
So main idea is to avoid those complications and give him a chance to perform his normal routine and keep him under surveillance. So that
And the concept came because when in our country there's no concept of autopsy, but when they saw in the other countries, they checked the autopsy reports. A lot of people who died because of other cause and found to have prostate cancer in their prostates. So that gave a concept that why treat them? They can live a normal life with that prostate cancer being a low risk. Sir, any comments from your side?
I have one query that is active surveillance is only specific for low risk patients having life expectancy greater than 10 years, or any low risk or intermediate risk?
No, this is not the option for the intermediate risk at all. This is for the low risk. Rather, this is good for the very low risk patient. We are going to discuss in risk stratification later. And obviously, if the patient has life expectancy of 2 years, then you will not subject him for the very extensive procedure like radical prostatectomy. So you need to see all the parameters. If he is fitting in all the parameters, then you will go for the active surveillance.
Dr. Naveed, can I add few words regarding question of Arslan? We can see if the patient has, as Dr. Naveed said, if the patient has life expectancy less than 10 years, suppose 2 years, so I think it's not, you can't subject him for the rigorous investigations like DRE, PSA, multiparametric MRI, rebiopsy for 2 years. For such patient, watchful waiting is an option.
How will you know that the patient has got a life expectancy of 2 years?
There are
My question for you. When I first read this thing, and I was very curious that how can you measure it, that how a person will live for 10 years or not. So any comments from your side? What is your idea regarding?
What answer you got?
I got the answer after a lot of research. I got the answer that it is the life expectancy of that region where you're living, and as well as the status of the patient. He has got comorbids or not. A patient has ki uncontrolled diabetes, uncontrolled hypertension, wo hai to there are chances ke uski wo kam hogi thodi. Or then another thing I read, 70 years plus 10, 70 years minus 10. So a lot of people defended this 10 years somehow. So I guess that
chronological age doesn't matter. We all know that Lata Mangeshkar recently died at the age of 92 years. So people can survive that long. But absolutely, the biological age is very important.
Yes.
For that, you need you have certain nomograms like ECOG status, performance status, and Karnofsky status. There are more. By these tools, you can measure the life expectancy of the patient.
So the concept of life expectancy is actually addressed and measured by a scientific field, and that is known as actuarial science. Now, actuarial science is actually something which is related to, in simpler terms, जो हम अपनी वो कराने जाते हैं, बीमा कराने जाते हैं, तो वो आपसे जो इंश्योरेंस पॉलिसीज हैं, वो इसको अगर वो ना करें, किसी के मुतालिक ये तय ना करें कि फॉर इंस्टेंस अगर आपने मशीन इंश्योर करनी है या आपने इंसान इंश्योर करना है, तो दोनों की कोई ना कोई शेल्फ लाइफ है. So it's a hard fact of life that everybody has got a shelf life. So humans have got a shelf life depending on the country or the region in which the person is existing. So all these insurance agencies, since the West is actually governed by, and their policies are actually written by all these agencies, so they have got their own calculations. So life expectancy is never something which is told by the physician or the medical literature. It is a terminology which is always taken from the actuarial science, the science which is actually the insurance policy like science. So इस वक्त जो है वो 85 years in the West for any male, or maybe plus minus 10 for a female.
For the prostate, the life expectancy can be measured by there are two famous nomogram, like palpable prostate and the Celine Memorial Hospital nomogram. You can check it on website and measure each patient's life expectancy by just putting the number of findings of DRE and the PSA and other the clinical stage.
कौन सा वाला आपने बताया मेमोरियल?
Memorial Celine Hospitals.
नहीं, it is Sloan Kettering
Sloan.
Memorial Hospital.
Sloan Kettering.
And actually, this Sloan Kettering Memorial Hospital is very next to the Wall Street, the famous Wall Street in New York. So I happened to be there. So everything on the next door, which is actually governing your health policy, is actually something coming from the financial sector, right? तो ये hospital जो है ना, इसके बराबर में वहाँ पे सब बड़े-बड़े banks हैं.
For the very low risk disease, the option is active surveillance. We will discuss the summary of evidence. The systemic biopsies have been scheduled in the active surveillance protocol, and number of frequencies of biopsies are varied. There is no approved standard. There's no randomized control trial on this thing. Although per protocol, MR scans are increasingly used in active surveillance follow-ups like multiparametric MRI, but with no conclusive evidence exists in the terms of their benefit and whether the biopsy may be omitted on the basis of imaging findings, or biopsy should be done on if we have no progression in the disease status of the patient. The personalized risk-based approaches with ultimate replace protocol-based management in the patients of active surveillance.
Can anyone from the audience define what do we mean by systematic biopsies?
Trust-guided and transparent.
Do we call them systematic?
Systemic.
Hexacore, octacore, सुना है, sextant biopsy. ये आपकी assignment है, आगे चलो.
For the selection of patients, they're saying that in the guidelines or after the studying the different researches, that life expectancy is more than 10 years and the disease risk is very low. You should offer the active surveillance to the patient. And if the patient has upfront multiparametric MRI followed by the systemic or targeted biopsies, there is no need of confirmatory biopsies. Patient with intraductal, these are the histological patterns on the trust-guided biopsy or transperineal biopsies. There are patterns, intraductal cribriform histology, they are associated with the progression, and these patients should not be given the option of active surveillance. And patient should undergo the multiparametric MRI before a confirmatory biopsy. If no MRI has been performed before the initial biopsy, we should offer the active surveillance. If we should taking the both targeted biopsy of any patient of pyroids more than 3 or equal to 3, or systematic biopsies, if the confirmatory biopsy is performed, should offer the active surveillance. And the follow-up strategy is according to the serum PSA every 6 monthly, DRE every 12 monthly. And we should counsel the patient regarding the possibility of needing further treatment in the future if the disease is progressing or if the patient is having raised PSA sequential. And the active treatment, we should offer the surgery or radiotherapy as an alternative to the active surveillance to the patient who are suitable for such treatments or who accept a trade-off between toxicity and prevention of disease progression. This is very weak strength because like in previous lecture, the Professor Saab was saying that you should have to be convinced, you should have to convince yourself before giving option to the patient that which options you are going to discuss with the patient. Pelvic lymph node dissection in localized prostate cancer, it is not recommended. Radiation treatment, there are two types of radiation treatment called the brachytherapy, low dose or high dose, external or internal radiation therapy. Use intensity modulated radiation therapy plus image guided radiation therapy with a total dose of 74 to 80 gray or moderate hypofractionation of 60 gray in 20 cycles in 4 weeks or 70 gray or 28 fraction in 6 weeks without androgen deprivation therapy. There are other therapeutic options like they do not offer the androgen deprivation therapy as a monotherapy to the asymptomatic man not able to receive any local treatment, or only offer whole gland treatment such as cryotherapy, high intensity focus ultrasound, like we are cyber knife to these options as another option for the treatment of low.
Numan, if you go back to the previous slide, now there is a very important message here. For instance, as we were discussing a little while ago, that the only indication for active surveillance is for those cases who are low risk or very low risk. But in the definition of a low risk, I don't think there is a mention of any kind of histopathological pattern. Now here comes a point, which is patients with intraductal and cribriform histology on biopsy should be excluded from AS. Now there is a very strong, this is a very strong statement. So if you want to have an active surveillance, even if your patient is having a very low risk, but if you see this kind of intraductal pattern or cribriform histology, then you must not be just set aside and satisfied that your patient is on such active surveillance list. No, you have to do something actively rather than just do surveillance. So put that patient under your watch list of something to do with preemption,
Yes.
rather than staying for the patient to tell you that I am now moving ahead in terms of morbidity, right?
Yes.
So जब भी आप ये वाला pattern देखें, then you have to step up rather than step down.
Exactly.
अच्छा, आपने अभी cyber knife की बात की थी. I don't think there is a place for cyber knife. It's not written here. You have said something about cyber knife. What's your concept about cyber knife?
So we will be discussing in next few slides.
अच्छा, सही.
For the treatment of intermediate risk disease, we have options of active surveillance for the selected patients and who don't have the danger signs like these histological patterns or continuously rising PSA or infiltrative pattern on the biopsy. We can offer the surgery like the radical prostatectomy, and we can offer the radiation therapy, recommended intermediate modulated radiation therapy for the intermediate risk prostate cancer or the brachytherapy alone. Other options are high intensity focus ultrasound or androgen deprivation monotherapy. And there are types of radiation therapies like external beam radiation therapy or brachytherapy. In external beam radiation therapy, after simulation, we focus on a machine to the prostate or a specific site of prostate and give the radiation of particular grays to the patient. Of the brachytherapy, like internal radiation, in which the radiologist or the medical oncologist, they put the radiation emitting substances in the prostate. These are for few days, or it can be for the permanently placed. It can be removed later in the high dose therapy. External beam radiation, there are different types, and these are the updated versions of the previous type, like 3D conformal radiation therapy, in which we look the prostate in 3D vision on the imaging machine and then give the therapy to the particular part of the prostate, or intensity modulated radiation therapy. You give the pulses of the radiation to that prostate mass or prostate area, or image guided radiation therapy, volumetric modulated radiation therapy. In volumetric modulated radiation therapy, you can give the high pulses or high fraction of the radiations to the prostate for a few minutes or few seconds, and it can be a daycare procedure. And stereotactic body radiation therapy, and means the machine is moving around the patient and it is continuously giving the radiation to the particular site. And the stereotactic body radiation therapy, also known as gamma knife, X knife, cyber knife, or clinic. Patient is on the table and the machine is moving around it, and machine continuously, by taking the multiple images, it is focusing only the single organ. And in this type of radiation, the chances of damaging the adjacent structure is minimum, but there are chances. And there are the sixth type is proton beam radiation therapy. In proton beam, another five, the difference is in other five the radiation therapies are like the X-rays, but in proton beam radiation therapy we are focusing or targeting the photons on the prostate. It is less damaging than the all above. We can give the proton beam radiation therapy in large doses to the patient with the prostate cancer.
Now, just to add one thing, in our unit in SIUT, we have got all within these 6, we have got 5. The 5th one, that is this stereotactic body radiation therapy, it's not available here, but all others are here. For instance, for proton beam radiation therapy, what you do is you take a proton, and this is a kind of a hydrogen atom, and you try to amplify its its velocity. You can amplify its velocity by moving it within a certain magnetic field, and then when it has reached a maximum or an optimum level of speed or velocity, then it hits the body. So it has got, as you have said earlier on, it has got a very low potential of collateral damage. Now, as far as this stereotactic body radiation therapy is concerned, till this day, the knowledge is it is more effective in tumors of the central nervous system. It has been used for prostate. It has been used for other tumors also in urology, but still it is not a part of the journal guidelines. So CyberKnife is being done in this city also for the purpose of prostate cancer, but it's not recommended. So no a medical oncologist actually prescribes it. So somebody is doing it, but it is out of the guideline.
Yes, sir. How we give the brachytherapy? There are 2 types of brachytherapy. Number 1, temporary high dose brachytherapy, and the permanent low dose brachytherapy. In temporary high dose brachytherapy, after localizing the prostate by the transrectal ultrasound, and we localizing the prostate and the part of isoecogenic or heterogeneous area, where the we can see the tumor is there. We put the nylon catheter in particular tubes, the little tubes, and put the 2 radioactive, like iridium 192 or cesium 137 is the radio emission elements. And after putting the catheter needles, and we place the nylon catheter and put the substances in it. And then after 1 or 4 brief treatments over 2 days, the radioactive substance is removed. And after the last treatment, the catheter also removed. It acts as a local radiation emission substance, which irradiates the prostate surrounding it. It has its own advantages and disadvantages. We will discuss in a few coming slides. And the permanent low dose brachytherapy involves a permanent placement of radioactive seeds in the prostate gland, where they slowly release the radiation over several months, like iodine 125 or palladium 103. Usually around 100 seeds are placed, but this depends on the size of the prostate. For intermediate risk disease, Aslan sir was asking about the active surveillance. Active surveillance is in highly selected patients of intermediate risk disease like ISUP grade 2, group 2 disease. If less than 10% of pattern 4, PSA is less than 10 nanogram per ml, or on CT scan, the clinical staging of the patient is equal or less than 2A. Low disease extends on imaging or biopsy and accepting the potential increased risk of metastatic progression. But these patients, if we are offering them active surveillance, we are regularly checking on them. We are taking them in our watch list. And if there is a progression of the disease or the PSA, or on the repeated biopsy or targeted biopsy, systemic biopsy, there is a progression in the pattern of the histology, we offer the other treatment. We will not continue on the active surveillance. We can offer the brachytherapy or radical prostatectomy for these patients. The radical prostatectomy is a definitive procedure offered to the patient with the intermediate risk disease and life expectancy more than 10 years, and nerve sparing surgery to the patient with low risk extracapsular disease. We can avoid the neurovascular bundle on the posterior side of the prostate, either unilateral or bilateral. A pelvic lymph node dissection is not recommended for the intermediate disease patient. Extended pelvic lymph node dissection. Radiation treatment, low dose therapy, as we have discussed, in the patient with ISUP grade 2 or less than or equal to 33% of biopsy cores involved, without a recent transurethral dissection of prostate or with the good international prostatic symptom score. And for the intensity modulated radiation therapy plus image guided radiation therapy, use a total of fraction 76 to 78 or 70. The range of radiations to the prostate are given in the gray is between 70 to 80. But the fractions can be different. It can be given in the 20 fractions or 28 fractions over 4 or 6 weeks in combination with the androgen deprivation therapy. In low risk disease, you are not advised according to the guidelines to give the androgen deprivation therapy alone. But in intermediate risk disease, we give the androgen deprivation therapy also. In patients who are not willing to undergo the androgen deprivation therapy because of their risk factors of on all of the body, use a total dose of IMRT plus IGRT or moderate hypofraction, or a combination of brachytherapy with the external beam radiation therapy. Other treatment options which offer the whole gland ablation therapy like cryotherapy, high intensity focus ultrasound like the CyberKnife or X-Knife or Clinac. These are just still under the studies. They have not concluded the results that these are superior to the other therapy, but we offer the other therapy as the sir was saying. And do not offer only androgen deprivation therapy to intermediate risk asymptomatic men who are not able to receive any local treatment. For high risk localized prostate cancers without progression through the prostate capsule or beyond the prostate capsule lymphadenopathy, we give the radical prostatectomy or external beam radiation therapy. And other than the primary treatment, other options like HIFU or CyberKnife for the localized prostate cancer high risk. There's a lack of evidence supporting that any other treatment options apart from the radical prostatectomy or radical radiotherapy in localized high risk prostate cancer. What are the guidelines saying? That you should offer the definitive surgery, radical surgery with high risk localized prostate cancer as a part of the potential multi-module therapy. And the extended pelvic lymph node dissection, perform extended pelvic lymph node dissection in the high risk and localized prostate cancer. And do not perform the frozen section of nodes during radical prostatectomy to decide whether to proceed or with or abandon the procedure.
This is again very important, and it has been rated as a very strong statement. Do not perform a frozen section of nodes during radical prostatectomy to decide whether to proceed with or abandon the procedure. Now, you see, whenever somebody who is a urologist and doing radical surgery like cystectomy or prostatectomy happens to do lymphadenectomy, they often think that both the things are similar. For one or the other, we can send the frozen section and see what's happening. That is not the case. That is still not the case with radical prostatectomy. And the biggest critical statement against robotic surgery is they don't do lymphadenectomy. And some of them have come up with the statements that it's not actually necessary because you have done all the preliminary workup. And since the tumor is confined to the capsule, it is confined to the prostate, there is no need of doing this kind of lymphadenectomy. Now, gone are the days. You have to combine, for instance, if you don't want to do it, you have to prove it. Now, how can you prove that your point is valid? That means that those who don't want to do lymphadenectomy when they are doing robotic surgery, Haris is not here, otherwise I will discuss with this point with him. Because if you combine your procedure with indocyanine green and see the fluorescence, then you got to know whether the disease is there in the lymph nodes or not. And the most heavily loaded lymph node will be giving you the highest amount of green color, the intensity, and that would be the sentinel lymph node. Now that lymph node might be at the bifurcation of aorta. That lymph node might not be at that point, maybe at a very high point. So you see, science doesn't go by your intention. It goes by your evidence. So the evidence still is that you have to take the lymph nodes. You can't just say that since I have done a very good job, I have spared the nerves, I have put those two dreaded complications of prostatectomy, radical prostatectomy aside, and this is not needed. This is needed because the main purpose of doing radical prostatectomy is to do away with cancer, not to have something like good quality of life. That is secondary thing. First thing is good quality of life, yes. But for instance, cosmesis is not number one thing. Number one thing is still eradication of cancer.
And in patients who are not a suitable candidate for the surgery, we can offer the high-risk localized disease treatments like external beam radiation therapy along with the internal beam radiation therapy in combination with long-term androgen deprivation therapy for 2 to 3 years. And these are the very weak strength, but we can offer in selected patients. Therapeutic options outside surgery and radiotherapy do not offer either whole gland or focal therapy in high risk localized disease like they are still under the study and only offer the androgen deprivation monotherapy to the patient who are unwilling or unable to receive any other local treatment. If they have prostate specific antigen uptake time less than 12 months, or either a PSA is more than 50 nanogram per ml or fully differentiated patient. We will discuss the factors for which the patient is not suitable for the radical prostatectomy surgery. And these are new things and still under study, and people are using it. Molecular biomarker prognostic assays commercially available for the use in males with clinically localized prostate cancer for the detection of the progression or recurrence. And these names are Decipher biopsy or Decipher postoperative or oncocytic differential GPS, and Polaris biopsy or Polaris postoperative ProMark proteogenic or prognostic test for prostate cancer. These are the molecular biomarkers you can detect in the serum. And the studies are still undergoing these are recommended. They are very high costing to the patient and to the economy. The advantages of main treatment options for the early prostate cancer. The external beam radiation therapy is effective in a long-term cancer control with high dose treatments and very low risk of urinary incontinence. Available for the cure of the patients over the wide range of ages in those with significant comorbidities like other hypertension, diabetic, or other heart conditions or other problems. The brachytherapy, it can control the cancers equal to the surgery or EBRT for organ confined tumors. It is quicker than the external beam radiation therapy. Available for the core of patient for wide range of ages in those with some comorbidities. Radical prostatectomy, in radical prostatectomy, you have taken the whole gland with the tumor out, and the prediction of prognosis can be more precise based on pathological features of the whole specimen. Pelvic lymph node dissection is possible through the same incision, and PSA failure is easy to detect. And active surveillance, it reduces the treatment. In this patient, you can make your patient free of the toxicities of these two other treatment options, and it has no effect on work or social life, but it can make the patient anxious that he is living with the tumor, having the tumor inside it. What are the disadvantages of external beam radiation therapy? A significant risk of erectile dysfunction because you are focusing the area which is supplying to the corporas and the nerves are there, and the lack of lymph node removal, late rectal symptoms, more commonly proctitis, which are happening with the brachytherapy or radical prostatectomy. A knowledge of possible metastasis to lymph nodes is not available. This is a disadvantage, and up to the one half have some temporary bladder or bowel symptoms during this treatment. And brachytherapy, they also have the significant risk of erectile dysfunction because the material which you are using, palladium or other iodine, it is emitting the radiation, and it also irradiates the normal neurovascular bundle around the capsule of the prostate. And we cannot remove the lymph nodes or ablate the lymph node during this procedure. And up to the one half of the patients have some temporary bladder or bowel symptoms. With treatment, there may be exacerbation of pre-existing lower unit tract obstructive symptoms, because it can also cause the fibrosis around the bladder neck or shrunken the bladder neck. Patient can have the obstructive symptoms, or in radical prostatectomy also, if you have tied the neck. Radical prostatectomy, significant risk of erectile dysfunction is still there due to the loss or compression or transacting the neurovascular bundle, and risk of operative morbidity is there. It is a pelvic surgery. Patient can land in the DVT or other symptoms. Low risk for a long-term incontinence. If you have only taken the prostate and you have not damaged the bladder neck, patient cannot have the long-term risk of incontinence if only the prostate is removed. The active surveillance tumor may progress at any time. As far as we know that prostate cancer is a very very low progression rate, but it can progress in patient with active surveillance, and later treatment may result in more side effect due to the if the patient is on active surveillance, but the tumor is progressing and we have not detected the patient. In our part of society, there's a lot of patients who lost to follow up for the active surveillance or watchful waiting on their so they can have the damage of this active surveillance method, and living with untreated cancer may cause anxiety. It is the main factor for the patient to live with the tumor inside it, either it is progressing or not. What are the relative contraindications for the main treatment options of early prostate cancer? External beam radiation therapy cannot be offered relatively to the patient with previous pelvic irradiation for any other pathology or the same pathology. There is active inflammatory disease going to the in the GI tract, like the inflammatory bowel disease or proctitis or localized other diseases. And the patient whose bladder capacity is very low, less than 1/3 of the normal bladder capacity, chronic, moderate, or severe diarrhea from any other cause, it is a contraindication for the external beam radiation therapy, because it can damage the adjacent structure like the bowel or neurovascular bundle. But there are chances. The brachytherapy, if there is a previous pelvic radiation, the volume of the gland is very large, and you cannot pierce with your catheters and needles or nylon catheter the whole gland. You cannot map it transperineally. Marked widening symptoms, patient is having the obstructive symptoms, increased frequency or low unit tract symptoms, intermittency, large or high grade tumor burden. If all 12 cores are positive with more than 33% of the positive rate, the brachytherapy has a relative contraindication. You have to offer the other treatment if it is having cribriform or other dangerous pattern or not. Active inflammatory disease of the rectum. The radical prostatectomy, if patient is having high medical operative risk, like the patient cannot undergo the proper anesthesia due to the heart condition or other comorbid, like patient is having the other vascular disease, or patient is having the hypertension, uncontrolled hypertension, uncontrolled diabetes, or ejection fraction is very low, you cannot offer the radical prostatectomy in these patients. So patient is having cannot make the position of the patient due to the other surgical or anatomical anomalies. The active surveillance has a contraindication with high prostate cancer, anxiety, and high-grade tumor more than Gleason 6 and not a stage T1C, or prolonged expected survival. The active surveillance can cause the damage in these cases. The relative contraindication of active surveillance. If there's any question regarding the local management of localized prostate cancer and treatment option, you can ask.
I have one question from Professor Asad, that which radiation therapy is best treatment modality for prostate cancer? And second thing is, with the advancement of technology like its cyber knife, by using fiducial particles like gold or platinum. So what do you think and what's your take on, is these are more beneficial for prostate cancer or not?
No single prostate is actually for each treatment. So each treatment has to be tailor made according to the prostate as well as the stage of the prostatic disease. For instance, you have got brachytherapy. Now, for brachytherapy, there are certain anatomical confines. For instance, if the inferior pubic arch is too narrow, you can't place the needles properly. So it's not one solution for every prostate. So every prostate, every anatomical position within the patient's habitus, body habitus, maybe the weight of the patient, the bulkiness, all these things come into play. As regards stereotactic or the cyberknife, still it's not the main guideline for prostate cancer. Maybe in times to come it will, but I don't think so that it is still in vogue, in fashion. The second point is about the gold particles. Gold particles were earlier used as radioactive material impregnated upon them, but the problem is the radiation dose is not actually within the control of the person who is applying it. The half-life is like maybe 10 years. So for 10 years, the radiation dose will be on a very high scale. And after 10 years, it drops down to half of that. So you can't just put everything out. So we have seen certain cases, I myself have seen certain cases where the permanent beads were present in the vicinity of the prostate, and those beads were impregnated with radioactive material. So within a period of like 5 to 10 years, they were not only radiating the prostate, they were also radiating the adjacent organs. And the most important organ is the bladder. So I've seen those bladders which were not actually radiated, but they are in the line of radiation. They become very much hypoplastic. They have got very low capacity, so much so that it's the capacity of like your thumb or maybe your finger. So they are reduced to such an extent. So radiation cystitis is a phenomena which is very much dreaded. So I think as far as your question is concerned, there is no single treatment for every prostate. You have to do a lot of homework and exercise.
So just a query, sir, as you suggested that endocyanin-based sampling of the sentinel node should be done. What if it comes out positive? Are you suggesting that we should not proceed with prostatectomy after it comes out positive?
No, you should, but the extent of lymphadenectomy, it will show you the extent of lymphadenectomy. It's not the case that for every prostatic cancer, you have to do extended lymphadenectomy. Why you want to do extended? Because you want to include the sentinel lymph node, the lymph node that is draining the most of the disease. Now, though that sentinel lymph node will be marked by indocyanin green more pronounced, in a more pronounced fashion. So you will be able to do your job correctly rather than incorrectly. So the incorrect job actually turns somebody like us or maybe somebody else that it's not needed, because the lymph nodes that we are taking, they are never coming positive. So why should we take it? And that's the reason why most of the cases in the West and still maybe in the East also, who are done under robotic surgery, they don't include lymphadenectomy in robotic prostatectomy. They are more concerned in sparing the nerves or taking the nerves in. They are more concerned with bladder neck reconstruction. They are not concerned with lymphadenectomy.
Previously, when we were residents, the recommendation was that if these nodes come out positive, then do not proceed with prostatectomy.
Yeah.
Because the disease has gone beyond the confines of the prostate. Now the recommendations have changed.
Yeah, it's changed because the platforms are not changed. You see, you are doing surgeries like with most of the surgeries are done through laparoscopy or they are done through robotics. Now your tactile sensation is now different. You are not able to palpate many things. You have to think in a different dimension. So that's the reason why everything is changing.
Yes, Usman.
Sir, I had one query in my mind. Suppose if we have undergone the brachytherapy for the patient and later we find out that he has obstructive symptoms, what options do we have to treat his large prostate? Like, still we have option of TUR or medical therapy, or how we treat this patient? Like in our scenario, we do channel TUR. So is that channel TUR is the option left who had undergone brachytherapy initially? And the other queries regarding the intensity modulation radiotherapy, what actually hypofractionation does, or what are benefits of hypofractionation?
Now the concept, second question first, the concept of hypofractionation is now challenged. It is not challenged to an extent that maybe we can move on to a single dose, single session, high dose, say application of radiotherapy, rather than putting that dose, which is like maybe 78 gray, into different smaller doses upon maybe divided into 35 days. So now, if the person is able to withstand, do a one session of 78 gray, that has got more value rather than having this patient coming on to you for every smaller sessions, 35 days or many weeks. So now the concept is this. So hypofractionation is something which is now challenged in recent literature, and you have got one article in the Nature Urology Review in your library also in the last month. If you want to study it, you are most welcome to have it, and then we can discuss amongst ourselves. So this hypofractionation is something maybe of the past. It is not challenged. The second thing, the second question was brachytherapy and its complications. Yes, it has got the same kind of complication as radiation has. It will lead to contracture of the bladder neck. It will lead to a lot of havoc to the bladder capacity. So rather than doing something for the bladder neck, we do something for the prostate, and that is TORP. Now, if TORP is done first and brachytherapy later, the brachytherapy then will be difficult because you will not be able to place in properly the needles, because there is no meat there. There is just a fossa up in the prostatic urethra. So it's an empty space. So you need a space where you put in the needle and then radiate. So if the person has got obstructive symptoms and have got the disease for brachytherapy, then you do brachytherapy first, TORP later. So that's the answer.
So let's conclude the session. Thank you so much, Noman. It was a nice presentation on very short notice. And thank you, Professor Asad, for such a guidance. Thank you, Bilal and Usman as well, for contributing in our today's session.